Hello, everybody, and welcome to today's webinar. My name is Elena Sturman. I am the President and CEO of the Glaucoma Foundation, and I am so excited that today we have three experts for our webinar on critical role of visual field testing in glaucoma management. We are going to dive into traditional perimetry techniques and the growing fields of remote home testing and virtual reality perimetry. Our goal is to give you insights into how these innovations enhance access to testing, improve patient comfort, and potentially revolutionize the way visual field assessments are conducted in glaucoma. Let me introduce you to our three experts tonight. Dr. Gus Demarais is an associate professor of ophthalmology at Columbia University Medical Center, New York Presbyterian Hospital, and he is also chief clinical officer at ORA. He is a clinician and surgeon with expertise in glaucoma, anterior segment, and general ophthalmology. His primary research interests are in novel techniques for glaucoma diagnosis, endpoints for clinical trials in ophthalmology, and new treatment modalities, both medical and surgical. Based on his research, Dr. Demarais has been ranked among the top 10 glaucoma experts in the world. Dr. Manos Tsamis received his bachelor's degree in optometry from the Technological Educational Institute of Athens and gained hands-on experience in an optician optometrist practice before earning Master of Science degree in investigative ophthalmology and vision sciences from University of Manchester in England, followed by a PhD in medicine optometry. Dr. Tsamis is an assistant professor of ophthalmic science at Columbia University, leveraging his unique educational path and diversity of expertise to advance research and understanding in this critical field. Hilary Golden is a patient and glaucoma coach. She is also a keynote speaker, consultant, and advocate. Living with severe glaucoma and bringing a bold, outside-the-box approach informed by her own journey as a patient, redefining success for eye care industry partners, doctors, and patients alike. Living with glaucoma gives her a rare edge. She understands the patient's fears, needs, and hopes firsthand. As always, there will be a question and answer session at the end of our webinar. You can ask a question by using a chat or Q&A button, and we will do our very best to answer as many questions as we can. Please welcome our experts. We will start with Dr. Gus Demarais, and let's begin.
Thank you, Elena. It's a great pleasure to be here with the foundation, the Glaucoma Foundation again. I'm very happy to see we have over 200 people already joining us, or close to that. And I'm happy to present a little bit about visual fields. I know this is a topic that scares a lot of patients. Not many people, including physicians, like this test. But as you'll see later, this is a very important test for management. And what I'll be showing here are just the basic principles of understanding what those numbers are, what the test is about, how to interpret some of the numbers here. And just as an introduction, there are many ways that we call the visual field test. Perimetry is a technical name, so you see a lot of times it's called standard or static perimetry, automated perimetry, or just white-on-white perimetry, but they all refer to the same one. And here you may be familiar with this. This is the Humphrey machine. That's the one we use most widely in the US. So the first thing that's important to know is that automatic perimetry is not very sensitive in the early stages of glaucoma. That means it does not usually detect defects in very early stages, all right? There are some studies that correlate the number of ganglion cells, of neurons in the retina with visual field. And what they show, like in this graph here, is that in many patients, you need to lose a lot of ganglion cells before the visual field starts to be abnormal, if you use some summary index like the mean deviation. So in general, you see a lot of times patients who have loss ganglion cells and have not had visual field loss present yet. Therefore, anytime we see an abnormal point on the visual field, that's alarming, because any point means that a lot of ganglion cells have been lost, a lot of neurons have been lost. So when I see a visual field like this, with just one point here highlighted, it does not mean to me that's early glaucoma, but at least moderate glaucoma, because there's some visual field loss. So if it's so not sensitive and highly variable, why do we still use it? Well, it's the gold standard to define the severity of glaucoma for us ophthalmologists, and it's the method, the test that best correlates with your quality of life or your perception of your quality of life. This is just an example of some graphs that correlate one of the indices of the visual field, the mean deviation that we're going to talk about later, and ability to drive. Also, the correlation between that same index, mean deviation, with the physical status and mental status of the patient. So when there's worsening of the visual field, there's usually worsening of quality of life. So for doctors, it's very important to watch the visual field, because although the patient may feel like their vision is worsening, we need to see that shown on the visual field to be certain of that. And finally, the other reason we use visual fields is that all the randomized clinical trials in glaucoma use visual fields as a primary endpoint. So whenever you see in the different stages of glaucoma, early, moderate, advanced, all the clinical trials show that lowering the pressure is effective. And you may have seen at some point someone say that each millimeter of mercury of pressure reduction reduces the risk of progression by 10%. Progression here is based on visual field. So that's what, when we decide what's the target pressure, how to treat a patient, it's usually based on studies that use the visual field. So let's dive into this, the printout, which you see here. So some important concepts. So first of all, you may have seen people say the 30-2 or 24-2 visual field or 10-2 visual field. So the first number, the 30, means the degrees from the center of your retina. So a 24 degrees visual radius is a 24-2. A 30 degrees radius is a 30-2. And a -2 means that both sides of those lines, the horizontal and the vertical lines, are tested. So that's where the name comes from. But remember, even like if you're talking about 24 degrees, this is just a small part of your visual field. This is just showing what your actual visual field looks like. If you cover one eye, it's much wider, 106 degrees horizontally and 135 degrees vertically. And when we do a visual field, we're just testing a small part of it, right? Even though it's called a peripheral visual field test, it's testing on largely the center of the visual field. That's why a lot of patients may have like a very depressed visual field, but they can still do a lot of things because the remaining of their peripheral vision is still preserved. So here's an example of 30-2. When that affects the central part of the visual field or the macula, we go to a different strategy called the 10-2, which will look at a smaller area of the test with more points and give us more detail about what's going on in the central part of your vision, which is the part that we use for activities like reading, recognizing faces, and driving. So let's understand the graphs of the visual field. The first one shown here is the numeric graph with those numbers, and next to it on the right, the grayscale graph. Those numbers correspond to the threshold sensitivity of each part of your visual field. And the threshold sensitivity is basically the dimmest stimulus that a patient can see at least 50% of the time. So if I have a bright light and I show it 100 times, if you see 51 times, that's your threshold sensitivity. So if I make it dimmer, you're going to see less than 50% of the times. If I make it brighter, you're going to see more than 50%. So that's what the threshold sensitivity is. And in everyone, it's usually higher. We see better in the central part and decreases as we go to the periphery. And the way the test is done, in very simple terms, the machine is not going to test each point 100 times, because otherwise the test would last too long, way too long. So the way it's done is use like a 4-2-1 staircase approach, which is if a stimulus is shown here and the patient is seen, which is green, it's going to go down, make it dimmer. Again, if the patient still sees, it's going to keep going down until the patient does not see anymore. Once the patient does not see anymore, it's going to increase it, make it more brighter by 2 units, and so on until 1 dB, and gets to what we call the threshold sensitivity. The other scenario, the first stimulus, your patient may not see, and the machine will make it brighter and keep going up and down until it gets to the threshold sensitivity. So it's not unusual that you don't see the stimulus from the beginning, because the machine is going to test you to see what's the threshold for each point. And this is what the numeric graph looks like. As you can see, the central part is the fovea that usually has the highest sensitivities, and the points around it are higher as well. We have the blind spot, which is a natural blind spot. We all have it. So we don't see the blind spot. That's where the name comes from. And the machine is going to test from the center to the periphery. So that's why the test tends to be, the peripheral points are tested more towards the end. This is the grayscale graph. It basically serves the purpose of showing didactically what the visual field looks like. So here's the left eye. You see the blind spot. The patient does not have glaucoma. Everything is white. This is the case with glaucoma. You see the blind spot and the dark area. So to explain to patients, especially, like, this is what happens when glaucoma progresses. Then we have the total deviation graph, which is shown here with numbers, and below it some probabilities. It is basically the difference between your threshold sensitivities and the average of the normal population. So for example, if I have a point here that shows 0, it means that your sensitivity in that location is the same as the average population. If it's +3, it means that you're better by 3 than the average population. If it's -2, you're 2 dB worse than the average population. And this is the case in glaucoma. As you can see, more negative values are more suggestive of glaucoma. And the machine will give you these black squares when it's statistically significant. Then we have the pattern deviation graph, shown to the right here. It's a little bit more tricky to explain, but it's basically a method to adjust and show areas of focal damage. Because in glaucoma, at least in the early stages, the damage seems to be focal in one location. It's not diffuse, like cataract, for example. So by doing this, the machine helps the doctor differentiate if you have visual field loss from glaucoma or from other things, such as cataract, cornea, or retinal diseases. So this is an example. You see on the left, the total deviation showing some damage, but then on the right, once you filter for diffuse loss, the damage is no longer there. Then we're going to talk about the global indices. This is probably something you see very often, the doctors talking about, the mean deviation and the pattern standard deviation. In very simple terms, if you have a 24-2 test, the mean deviation is the average of those points on the total deviation. And the pattern standard deviation is going to be a standard deviation of those points. So, and this helps the doctor track how on average the patient is over time. So the MD of plus 0.15, like this example, shows that the patient is on average better than the average of the population. It also shows the GHT, or glaucoma hemifield test, which is a comparison between the superior and inferior, the upper and the lower part of the visual field. In glaucoma, at least in the beginning, the damage tends to be mostly only superior or above, or inferior or lower part of the visual field. And then it's going to tell if it's within normal limits, borderline, or outside normal limits. Here's an example. You see the total deviation, the pattern standard, the pattern deviation, and you see how the points, there are more points abnormal in the upper part than the lower part. So this is suggestive of glaucoma, and that's why the GHT shows outside normal limits. Finally, as among the indices, we have the VFI, which is very similar to the other two. The difference is that it transforms all those values into percentages. So now 100% means normal visual field, 0 means blindness or no visual field. And then the doctor can plot this over time and see how much change the patients experience in their visual field over time, from 100 to 80 to 60, and see if the treatment is being effective. This is an example. It's also good to check in patients who have cataract, for example, because the cataract can affect some of those indices. On the bottom here, you see the mean deviation, a steep slope, suggesting that the patient is progressing. But on the top, the VFI, you see it's not as steep. It's because this patient was not progressing from glaucoma, but the cataract was getting worse. So by easily removing the cataract, you can solve the problem. So it's not a case for glaucoma surgery. Then I'm going to talk about the reliability indices. So they're here on the top. That's how the doctor knows if your test is good or reliable. All right, that's something that patients are always concerned. Did I do well or not? So this is where we look at that. And there are these 4 indices. The first one is the gaze tracking monitor. So while you're doing the test, there's a picture, a video that shows your eye and tells the technician if you're moving your eyes or not. And it's going to show here in the bottom, if it goes up or down, means that you either moved your eye or you were blinking. Blinking is absolutely fine. Let me repeat that. Blinking during the test is absolutely fine. So don't worry if you're blinking during the test. But moving up and down to the sides is not good. Then you have fixation losses, which is based on where your blind spot is. So your blind spot, obviously you don't see your blind spot. So if the machine goes back and retests the blind spot, which it does, just trick you, basically. And if you see, it tells us that you moved your eye. So the machine checks that as something that you did, you moved your eye. Then we have the false negative responses. So remember the threshold sensitivity, which is the 50% of the times you see. So the machine will go back in every point without, of course, telling you, and go back and test it again with a much brighter stimulus than your threshold, which you're supposed to see because it's brighter. But if you don't hit the button, it's going to be a false negative because it's telling that you were not either pay attention or you fell asleep during the test. A false positive is the other way around. So you have the threshold sensitivity, you present something that's dimmer than that, which obviously you're not supposed to see. But if you push the button, it's either because you're too excited or you had some doubt about testing, and that's what's going to show here. And that's probably the worst index for us because it shows that the patient was overexcited pushing the button and doesn't tell us much. So in summary, that's what I want to tell. This is what the visual field looks like and how to interpret it in basic terms. And I'll give the opportunity now to Dr. Tsamis to talk about the new technologies. Thank you.
Thank you so much, Dr. Demarayes. Dr. Tsamis, take it away.
Thank you. Thank you very much. Thanks for having me here and for the great introduction. Okay, so I'm going to build up on what Gus just talked and showed us, and I'm going to talk about virtual reality technology, how we can start implementing this into visual field testing or perimetry. The obligatory financial disclosures, the one that is relevant to this presentation is consulting for a company that is developing their own VR perimeter. All right, so let's start with the transition from what is done in the clinic to virtual reality perimetry. As Gus showed, when standard automated perimetry was introduced back in the 1980s, that was a big revolution for perimetry. We went from all the manual ways of measuring visual fields to a more automated and faster way. But things didn't change much up until recently, the following 30 years. You can probably recognize the Humphrey field analyzer, the one that most practices, at least in the US, have on the top row, we have the octopus. So over these years, the devices became maybe a little bit smaller. A couple of other competitors showed up, but there haven't been many changes really. And that has effectively been the limitation of perimetry in the clinics, conventional perimetry, right? The devices are still very big. The testing algorithms haven't changed too much. They have this one size fits all, and they're not individualized for the patient if you must. Variability, Gus talked about this a little bit, it's still too large. And by variability, test variability, we mean you will do the test today, this morning, and you will repeat it again a few hours later, and the results could be slightly different, okay? Because at the end of the day, it's a subjective test. It's waiting for your response to take those measurements of your visual field. And because there haven't been too many changes over the years, the data analysis, the way we analyze those measurements are also out of date. So we really hope with introduction of new technology and evolution of screens and virtual reality technology, we really hope to transition from what we're doing in the clinic to something different, to other devices. But the reality is that psychophysics, which is the name for the science behind visual field testing, psychophysics are not that simple. It's not as simple as we're going to present on the screen a very bright stimulus. All these parameters are standardized. The stimulus has to have a specific shape. It has to be presented for a specific time. The background luminance has to have a specific brightness. The background has to be specifically calibrated. So it is not an easy task, okay? That being said, many have tried to do that to various degrees of success. And the number of virtual reality perimeters has increased over the past few years. Every year that we go to a conference, a clinical or a research conference, a couple more, and talk to those manufacturers. I have put here a few of them. There are quite a few more, but you might have already started seeing a few of those in some of the practices. So I'm going to go over some of these devices and some of the important questions that I think we should be asking now, because this is a new market, and when there is a new market, there's a potential for good and bad devices, right? And I think it is my opinion, at least, that we can all work together, clinicians and scientists like myself, and patients, of course, patient groups. We can all work together to make sure that the bar is not set low by bad products and bad devices, right? So what would be some questions that we could ask when we deal with such devices? We could ask, for example, the basic one: is it FDA registered, right? Is it FDA cleared? Does it follow some basic psychophysical parameters and respect psychophysical parameters? Is it faster than the machine in my clinic? Is it more comfortable? Can I take it home? Right? So we're going to go over some of those devices, and we're going to ask some of those questions. Here we have the Tempo from Topcon. It's actually the one device that has the most research behind it. A prototype of this device was presented to us by Dr. Matsumoto from Japan 6-7 years ago. Our community was introduced to something like this. So there's a lot of research behind it. The version that you see here, the version that is at the moment in clinical practices and in the market, is the 4th or 5th iteration. So as you can imagine, it has become better and better over the years, right? It is custom made, which means the manufacturer has taken care of the necessary optics and the necessary parameters that they're needed for visual field testing. And this is a huge advantage, especially for people with very high myopia, right? The off-the-shelf virtual reality headsets, it is possible that people with very high myopia could struggle to stay in such a headset for a very long time to get tested. On the other hand, the potential advantage of a custom-made headset is that it would be more difficult to find, it could be more expensive to make, right? It could increase the costs of it. So there are pros and cons of a custom-made headset. Back to Tempo, it's binocular. That means we have both eyes open and we can test both eyes simultaneously. And that usually leads to faster tests too. So the total duration of the test is shorter than what we do with the Humphrey usually in our clinics. And as I said, there is a lot of research behind Tempo. It has been improved over the years, and recent papers and recent studies have shown really high correlation with the Humphrey device, the one that we have in our clinics. And that is very important for home testing, which we will discuss in a few slides later. A potential disadvantage of the device that we see here is the fact that it is not portable. All right, as you can see here, it comes with a little band and a case for a computer and so on. So it won't be easy to just take it home and take it to your home. This is still for clinical practices with just a much smaller footprint as compared to the Humphrey, to the clinical standard, and likely more comfortable too than the Humphrey. Another device out there is the Radius XR, right? Another device that is FDA cleared. All of them, what I'm showing you are FDA cleared. And another one that is custom made, and there's no need for glasses. The manufacturer has put there the appropriate lenses that adjust the optics accordingly to each person's own prescription. Okay, and that's very important for visual field testing, to have that prescription and those optics properly adjusted. That's another one like Tempo, that both eyes are open during test, and recent studies have shown really high correlation with the Humphrey. A particularly interesting feature of this device is that the patient can review their own tests, as shown here in the picture, on a tablet or their own computer. So they have some control of what they just did, right? I think, to me at least, it was so important to do a test, see how you did. Maybe you can see that it wasn't as good as you thought, like with regards to reliability, right? Your performance, and you can repeat it again when you feel better a few hours later. A potential disadvantage, and that's a little bit technical, but I thought it's important to put it out there. It's the testing range, the limited testing range. And what I mean by that is that the Humphrey, the perimeter in our clinics, can test really, really bright stimuli. It can produce very, very bright stimuli. Those devices, most of them actually, in fact, all of them, cannot produce as bright lights as the Humphrey does. As a result, the testing, the range of the different thresholds and the different stimuli brightnesses that VR headsets can test is relatively limited. This is not necessarily bad, and that's a different conversation, a little bit more technical, but it's worth mentioning that you cannot achieve perfect replication of what the Humphrey and what the devices in the clinic are doing and what a VR headset, a VR perimeter can do. Another one out there is the Ollie Eyes. This particular device comes with two models. The ETS is considered to be the more advanced model. It has a few more features than the basic one, which is the S model. What differentiates this from other models is that according to the company, they have pediatric protocols. So they're able to test children 6 years and older. And their tests have some gaming elements. And that's actually a very interesting feature, because a test that is more engaging and a test that keeps the user more focused can reduce variability, right? It is more reliable. Ollie Eyes also has more visual function tests than just visual field. We can test the visual acuity with it. We can check color vision, for potential color blindness, and a number of other important visual function tests. A minor disadvantage of the Ollie Eyes is that from the current studies that are out there, the correlation seems to be lower than what others have achieved. Still quite acceptable, and something that, at least in our community, is considered important and quite high, but lower than what the other two devices, for example, that I showed you, have reported. Okay, so at some point, even now, we will reach a point where at least one, if more devices, will be good enough for us to be using in our practices. How we can implement them? What are the clinical implications and applications of VR technology? With glaucoma, the important aspect is to detect early, right? Our problem is late detection. Patients are unfortunately getting detected when the damage is already moderate to advanced in at least one eye. So can we detect such populations, such patients earlier, ideally even in the asymptomatic stage, at the stage where they don't even see a defect in their visual field, they cannot experience it, right? And if we detect early, we can intervene early. And if we intervene early, we can decrease the probability of blindness in the future, in a person's lifetime. So our ultimate goal as a scientific community and all the glaucoma specialists, our goal is to get visual field testing out of the clinic, right? And we strongly believe that VR technology can allow that and can let us move the visual field testing into, for example, practices that are closer to the patient, like the optometry practice, or the optician, as you go and you get your glasses fixed, or new glasses, Imagine being able to do a quick screening test too, just to check that everything is fine, right? Your primary care physician, maybe there are some criteria in there in your medical history that makes you prone to potentially having glaucoma, a family history of glaucoma, for example. And your primary care physician gets that headset out and does a quick visual field test to you, right? So we consider this very, very important for early detection. And why not at some point, places like a shopping mall for mass screening of the population. But what is particularly important, I think, for us is testing at home, the potential of putting these devices in patients' homes and being able to collect more data from a patient. When a patient is getting diagnosed with glaucoma, an average patient is being seen twice a year. And those visits usually involve a visual field test, right? I'm pretty sure most people here have a similar follow-up routine. At that point, the glaucoma specialist has quite a few tools to check if the visual field got worse or not. One of the simplest tools is to take the mean deviation value, the one that Gus showed before, which is effectively the number that brings your whole visual field down to one number, okay? And put this mean deviation value onto a plot and see how that changes over time, like the hypothetical example that I have done here with these red dots. Now, the problem with visiting twice a year is that it's not easy to see a trend, right? Is this patient, for example, getting worse in my example? Is that last visit, that last dot over on 2025, is it truly a test with like that the visual field got worse, or was it just a bad day? The patient just simply didn't perform that day. Now that imagine that patient having a VR headset at home and they're testing themselves once a month or once every couple of weeks and sends all that data to the doctor. And the doctor is able to add that data to that plot, to that trend, to be able to judge the trend. Right? And we will see here in that, again, hypothetical that I've created here, that the doctor will likely think that, this is normal variability. There are good days, there are bad days, the patient performs good or bad some days. So that looks pretty stable in general over time. Now let's take the same hypothetical, haven't moved the red dots, right? And let us assume those home tests here, the little triangles that I put in there. Now there is a clear trend that the field is getting worse that could increase the confidence of the glaucoma specialist that, this is the last test there is actually true. It is getting worse. And in fact, our holy grail, if you must, would be to even be able to alert the doctor earlier that visual field change has occurred. So that's it with VR technology. We're at the beginning of it, but we have really, really high hopes that if this is developed properly, we will be able to really, really assist with early detection in glaucoma, detect more cases earlier, as well as with the monitoring for changes over time. Thank you very much.
Thank you so much, Dr. Tsamis. We are very fortunate to have Hilary Golden with us, who has done numerous visual fields, and she also is very familiar with the VR perimetry, and she will offer her take on the technology and perhaps will share just a bit of her story. Hilary, take it away.
Thank you, Elena. And those were great presentations, and it's so nice to be able to, as a patient, to hear the science behind the test that we're doing, and because it makes more sense. The biggest challenge with visual fields is the fear and anxiety that it brings up. And the reason that it brings up the fear and anxiety is because it confirms what you can't see. So every time you go to the glaucoma specialist, you're in the waiting room, you're nervous, you're waiting for your name to be called, and you're going to be told if your vision is stable or if you've lost more sight. And that is a very, very big thing to be sitting in the waiting room wondering. So how I've handled my glaucoma journey is that knowledge is power. And the more I know and the more I understand about my glaucoma, the better I can control what I can and understand what I can't control. So it's made me evolve into learning more about it and understanding the glaucoma and being able to move forward and handle it emotionally as well, because all of that's important when you're a patient. And the visual field test is so important to measure progression. And without it, as both of the doctors were explaining, it's very hard to measure how you're doing if you don't have the visual field test. I was diagnosed in 2020, and an optometrist diagnosed me. She looked in my eyes first when they were dilated and said, "I don't like the look of your nerve." And that was the first indication that something was wrong. The first test she did was a confrontation test, which is just she had me cover one eye and she asked me how many fingers she was holding up. And as she did that, I said, "I can't see your hand. Am I supposed to be able to see your hand?" And she took a deep breath, calmed down, and said, "Just tell me when you can see my fingers." So I had my hand up, and then as her hand moved across my face, I said, "Okay, now I can see 3 fingers." Um, she knew from that that something was wrong. So I had already had the nerve not looking right. Then we had the confrontation test showing something's wrong. And then she said, "We need to do a visual field." So I went in to do a visual field, and it was very, they gave me little direction. I was told to press this button when you see a light. I had never had a visual field before, so when I put my head in there and keep your head still, and you're going to see a light, and I'm going to start the test, and they give you kind of an overview, but you don't necessarily know what it's going to be like. So as I'm taking the test, I said, "Well, I don't know if that was the light. Do I press it now? Okay, do I press it now?" So I'm talking as I'm doing it because I didn't know what to do. I got through the test, and it showed that there was a big scotoma covering, or a blind spot covering, about a quarter of my sight. So they sent me to a glaucoma specialist. Um, and that was my first experience with the visual field. A few months later, my glaucoma specialist did a visual field, and it was a tech who was on her second day of work. And she gets tasked with doing my visual field. We start the test, and I have the little button in my hand, and I'm waiting for a light, and I don't see a light, and I'm waiting. And it felt like about 10 minutes had gone by, but I'm sure it was only 30 seconds. But all of a sudden, I just started crying because I thought I was going blind and I couldn't see anything. And I just pushed the chair back from the machine and was in tears. And the tech didn't really know what to do. And she said, "We just need to get this visual field test." And I said, "I know, but I'm going blind." So the whole thing was really unnerving, because what I realized years through this is that the beginning part of the test, the lights are where my scotoma is. So that's why I couldn't see any lights. But again, this is what you learn over time. And being in that room with that bowl is really scary. And the evolution of the visual field is interesting, and being able to do an alternative test with the virtual reality headsets. I've done about 4 or 5 tests with different units, and the tests have been pretty similar to what my traditional visual field looks like. So as far as the accuracy for me, it's pretty on target. It's nice to be able to take the test in an exam room where you're in a comfortable chair, your neck's not like this, and your head's weird, and you have a patch over your eye with a Kleenex in it that's getting in your eye, scratching you. So all that's very uncomfortable, and it just makes it more taxing, physically and emotionally. It's a taxing test. So a lot of patients tell me that they're scared to fail the test. Well, you can't really fail the test. It's a barometer, right? So it's measuring where we are with our visual field, and what sight we have and what we've lost, and it's giving the doctor good information, but you can't necessarily fail it. It is challenging for everyone. So even if you don't have glaucoma, it's still a challenging test, and it's good for people to know that some of the flashes are meant to be missed. So you're not supposed to see every flash. As we discussed, a lot of the flashes are very faint to begin with, and then they get brighter, then they get dimmer again. So it's testing you to see what your baseline is, which is great to know. But of course, all this is not explained to you at the beginning. So you kind of have to figure it out over time. But I found, three things that have helped me during the visual field test. And the number one thing is to advocate for yourself and to tell the tech how they can help you. So when I've done a visual field test and, they put me in there, and then I've had techs that have walked out of the room and then walked back in, then walked out and walked in. And I tell them before, please don't leave the room. Please stay here with me. Please don't talk to anybody. It's very unnerving for me. So you have to explain what works for you. And then the other thing I tell them is, can you tell me when we're halfway through? And can you tell me when we're 75% of the way through? So I know when I'm almost done. And when they tell me that, then I know, okay, good, I'm halfway through. Then I kind of have a good baseline of where I am. Then they tell me, okay, you're almost done when I'm 75% of the way there. Then I know, okay, I just have a few more to go. And then, finally when I'm done, obviously. And then, we switch eyes. But it has helped me so much. And if I did that from the beginning, I think it would have helped me a lot more. The other thing that I tell patients that I've learned is to use either artificial tears or lubricating drops before the test. So I use it if I were doing my right eye first, I put the drop in my right eye, and I put, the patch on the left, and then I take the test. And then when we switch, I put the drop in my left eye. So I don't put the drops in both eyes first. Everybody can do it how they want, but it is easier for me to stay fixated on the fixation point, and I can stay looking at that spot. Whereas when I don't put the drops in, my eyes are drier and it's harder to stay focused. And so the drops have really helped me. And then the third tip that I'll give is, and I didn't know this until recently, but if you want to stop the test, you can hold the button down and it stops the test. So, that time that I got really upset taking the test, if I would have just held the button down, I think the tech can also stop the test on their own, but for it to come from the patient, you can hold that button down. And then that way it gives you just a chance to take a deep breath, or, if you need to cough or sneeze or something like that, then know that you're in control. You don't have to just say, hey, can you stop the test, and hope that the tech's listening. You can hold that button down. So that's something new that I learned. So all those can really help. And it's amazing to see what's going to happen with visual field testing, and to be able to take these tests at home is just amazing, because, you could have a bad day and get a poor test result, and then the next time you go in, it looks a lot better. Then the next time it gets worse, and the next time it gets better. So you don't really know where you are. But if you're taking it in a comfortable place like your home, then you can get a better read on where you are. Again, this knowledge is power, not just for yourself, but also for the doctor. And these test results empower the doctor to know how to treat you and where to begin with your treatments, and also where to go and how early they need to intervene with surgical options, perhaps. So this is really invaluable information. And while it is a stressful test and it is emotional, I very much appreciate that we have it, and that has evolved as it is today. Thank you.
Thank you so much. Thank you to three of you. We have a lot of questions. I am going to apologize in advance because I know we won't get through all of them, but we will do our best to answer at least a few. So let's start. And the first question is to our doctors, and one can start, the other one can continue, or you can decide which one will answer it. How does a cataract impact accuracy of the visual field test?
So it's a very important question. As the example I showed, this is something that can be very tricky, and the doctor can make a wrong judgment if he or she relies on what they saw in the visual field, always thinking it's glaucoma. And it's not just cataract, problems in the cornea, in the retina, they can also affect your visual field. So in terms of cataract specifically, two things are important. One, we know if you have cataract or not by examining on the slit lamp. So that gives us a hint on whether it's going to be affecting or not your visual field. If you already had cataract surgery or you don't have cataracts very early, it's extremely unlikely it's going to have any effect on the visual field. But once you have cataract, the key is that cataract causes what we call a diffuse loss. So it's not like just here, just there. Like glaucoma, usually, if you saw the examples, it's usually like very focal. Cataracts will be more diffuse. And we can see that on the test pretty much, especially after seeing you in the slit lamp. And then there's those two graphs that I showed, the total deviation and the pattern deviation. The pattern deviation uses an algorithm that, quote unquote, removes the effect of cataract. It shows just what's from glaucoma. So the test helps us see that as well. Dr. Tsamis, any other thoughts?
I don't have anything else to add apart from the fact that maybe I agree with you guys 100%, and the fact that I have seen different practices. There are doctors that once cataract gets to some level, maybe they will pause visual field testing for a few visits until cataract has been dealt with, and others that they trust the pattern deviation plot that you mentioned, and they continue visual field testing, and they ignore the part that gets darker and darker as the cataract gets worse. And then when the cataract has been dealt with, then the visual field test goes back, at least on the total deviation side, goes back to where it used to be. So
and again, on the clinical examination, if we see like the visual fields getting worse,
right,
the pressures have been always well controlled, patients compliant with the drops, but we see in the slit lamp that clearly the lens, the cataract got worse, then I'm not going to add another drop or do a laser or surgery because of that, because we can't correlate what we see in the clinical exam with the visual field.
Thank you very much. Next question is for Dr. Tsamis. Are there any visual field devices that are ready for home use?
Yes, that's a good question, and I think it lies a lot on every individual's confidence and leap of faith that they want to take, right? Because this is relatively new, and it's like, imagine the electric cars. When the first electric car came out, it was working, it was taking us where we wanted to go, but it wasn't as efficient, right? And then more electric cars came out and they became more efficient, and so on and so forth. So I think we are at a similar stage. If the second point I would put there is also something that you need to consult your doctor. There's not really any point of getting one of those devices if your consultant, the person that treats your glaucoma, wanted and believes in another device, or wants to wait and won't use that data really. So I think it would be into a conversation with the doctor what device they would probably recommend, and also potentially be prepared that a device that we would buy today, we may need to replace it in a year or two because something else would be out there.
Thank you very much. Next question is, how many visual field tests over a given period of time are best to identify progression?
Dr. De Moraes has done a lot of research on that, so
Yeah, so there are a number of factors that we take into account. The main one is the severity of the visual field loss or the severity of glaucoma. If you are a so-called glaucoma suspect or ocular hypertensive, we recommend to have 2 baseline tests, usually within 6 months or less. And then you can pretty much do once a year, okay? Once you start getting to the early level, we have some visual field loss, then twice a year. And in moderate to severe cases, 3 and even sometimes 4 times a year. Of course, this can change a lot. If the doctor has some suspicion, he can do more, even in the early stages or later. So that will depend. But as a general rule, that's what we find, and that generally helps us But it's one thing it's crucial, and that Dr. Tsami showed, is that the more tests in general is better. The problem is insurance, if they're going to cover or not. Ideally, if we could, we do more. And of course, the patients on that, because they don't like the test, maybe they would not like to have a test always done. But the more tests you have, more information, more certainty you have about progression.
Thank you very much. So the next question, I want a doctor to comment on it, and also Hillary, you, because it's the question about low tension glaucoma, and Hillary does have low tension glaucoma. And so in low tension glaucoma, is the visual field or pressure control more important?
Okay, so the answer is both. So the reason is the pressure tells the doctor right now about your risk of progressing in the future. So we know approximately what's the ideal pressure for you based on your severity. So I know that, for example, if someone has advanced disease, we like to see the pressures like in the low teens, for example. So I know that to prevent future progression, I'm going to be looking at the pressure a lot, because of course, by definition, I don't know those visual field tests in the future. So I use that to predict and to make sure you're not going to have it. Now, when I look at past data, so suppose your pressures are good, always within target, but I look back at your tests and they're showing you're getting worse. Even though in the beginning I thought your target was, let's say, 14, if you're at 14, but your visual fields are getting worse, I may actually add another drop to lower even more. Because again, all these estimates are based on the average of the population. We start with the average of the population, what we know in general, and then we tailor based on each patient as we follow. So the answer is both. For existing data, if you have a lot of visual fields, we're going to focus that to define your pressure. But if in the future, we'll make sure that you have the target pressure based on your severity.
Thank you very much. Hillary, you want to comment from your personal experience?
Yeah, so just like Gus said, with the visual field, they use a visual field and the OCT and the pressure, all three as a guide, along with your fundus pictures, so your optic nerve photos, to decide treatment. So that's the nice thing about having multiple modes, because if we need to get a lower pressure, or we need to do a surgery, then all these things are used for the doctors to make their decisions, which is very nice, because they're not just relying on the visual field. Because as you know, glaucoma is a group of diseases. It's not just one issue. So they're managing multiple things at the same time. So these doctors are doing, trying to use all these tests to work together to find out what to do next. And yeah.
You wanted to add something, Dr. Thomas?
I would like to add something that also, I apologize that I clearly can't go through quickly all the questions in the Q&A, but I noticed one that it follows up a little bit on what we're just discussing, and it's about, could we just scan the eye and take, stop having a visual fields and get the level of loss there? And it is not that easy. We have seen really strong relationship between structure, what we see at the back of the eye with imaging, and function. But first of all, it's not perfect. Secondly, the quality of life is really directly correlated with what the visual field measurements are, right? Now, though, what we could do, and we hope that, especially with VR technology and further evolution of perimetry, we could do, is to take, for example, an OCT, right, and see where the scotoma is, where the blind spot is, and then avoid a situation like the one that Hillary described, where the visual field test concentrates on an area that the person cannot see, and you're using all that time, 15, 30 seconds, a minute sometimes, on an area that is presenting something that, the patient cannot see. The patient starts getting stressed, and they perform effectively worse than before. So to what extent we can use that data from an OCT to then tailor our testing algorithms in the visual field and test more important areas, the areas that we truly want to follow up over time.
Thank you very much. We have time for one more question. And the question is, you talk about how important it is to track progression. Do any of virtual reality visual field devices have any published studies that show how they are able to measure progression?
Yeah, that is a very, very good question. It comes back to my comment that these are very early days of this technology and of these devices, and their first focus is to show how they can compare with a clinical device, the Humphrey field analyzer, the most common device perimeter that we have in our practices. So the vast majority of those studies are focusing on that. What's the correlation between the two? And the correlation is a deeper conversation, by the way. We could be talking about this for another hour. So further on that is detection. I think the next step, after showing that, okay, we can replicate more or less what the device in the clinic can do, then the next one is detection. Can we at least detect the people that that device would detect, the Humphrey would detect in the clinic? And then progression will follow. Right? So these are like three distinct steps. Imagine them like blocks that they're building upon each other. And at the moment, we're at the stage of trying to understand and quantify, if you must, that correlation between what VR headsets can do as compared to the Humphrey field analyzer. In short, no studies for progression yet.
Thank you very much.
If I may just add something on that. So we tend to use this correlation with the Humphrey as it was something important, but remember the Humphrey is not perfect, right? Mm-hmm. I don't need to tell the patients here that the Humphrey is not good enough. So it's just a matter of a metric, and there are other advantages that Hillary mentioned about comfort, repeatability that play a greater role. And finally, on the questions on OCT and visual field that Dr. Tsamis mentioned, it's basically because not in all patients, the two tests are going to agree. In some patients, the visual field is going to show the defect. In other patients, it's going to be the OCT. And especially when you get to advanced case, even though the OCT is more objective, it usually reaches a floor effect and it becomes very difficult to track progression. So that's why in the end, the doctor ends up doing both, even though the OCT is more repeatable.
Thank you very much. So we've reached the end of our webinar. I know there was a lot of information for our viewers. This webinar was recorded and it will be available tomorrow on our website and on our YouTube channel, so you can review all this information again and see what you missed and what you need to see one more time. I would like to thank our experts so much, Dr. Demarais, Dr. Tsamis, Hillary, for sharing your story and for helping patients understand. By the way, you got a lot of shout outs in the chat, just thanking you for sharing your story, Hillary. And I would like for our viewers to stay connected with the Glaucoma Foundation for more information, more webinars, and just new advances in glaucoma treatment. Thank you all so much for your time and have a good night. Bye-bye.